We all know this conversation. Patients coming in, upper respiratory symptoms, the midst of sick season. We have patients thinking that they need an antibiotic for the sickness that they have. And statistically speaking, we all know the vast majority of them will not warrant an antibiotic. They have viral respiratory tract infections. Let's get into these 5 main prescriber types. The first one we're going to talk about today is the people pleaser prescriber. The people pleaser prescriber says they do not need an antibiotic. This is viral, but she came in saying, I know my body, I know what I need, I just need an antibiotic, and I just don't have the heart to tell her no, or I just don't want to tell her no. I don't want to deal with the disappointment. They are strictly prescribing an antibiotic that isn't medically necessary because they want to please the patient. We have to remember one of the number 1 rules, the Hippocratic Oath, first do no harm. That's a line that I use with my patients. My job as a practitioner is to first not hurt you. My second job is to help you. That's a line that you can borrow when it comes to avoiding unnecessary antibiotics. We know some of the detrimental side effects they can have, but it's even worse if that antibiotic wasn't warranted and they suffer adverse effects from an unnecessary antibiotic. When you're prescribing without having that conversation, it is a slippery slope. You are building expectation and reinforcing the patient believing they're right. You are solidifying incorrect thinking, contributing to the problem of patients demanding antibiotics, and of course, the worldwide issue of antibiotic resistance. Don't be a people pleaser in this way. So let's talk about prescriber type number 2, the fence straddling fumbler. The people pleaser wanting to avoid disappointment for the patient. The fence straddling fumbler wanting to avoid confrontation. They may even tell the patient, you really don't need this, but here's an antibiotic just in case. They know the evidence, but they hate the confrontation and they're ready to avoid it no matter what. They're essentially handing the medical decision making over to the patient. If patients could determine when they needed an antibiotic, they would be available over the counter, and they're not for a reason. The fence straddling fumbler causes confusion. Do I need it? Do I not need it? I'm supposed to decide? It is not the job of the patient to determine if an antibiotic is needed or not. Now, that doesn't mean that a patient doesn't come in at times and they're absolutely right that they need one, but the ultimate assessment, diagnosis, and treatment comes down to our job, not the patient's. In defense of the fence straddling fumbler, they probably have had some type of confrontational encounter with a patient before that was really upsetting, and they're just not going to spend their energy having this debate and dealing with this. They're going to let the patient know they don't think it's warranted, but they're going to give the antibiotic anyways. This is less about disappointing the patient and more about avoiding confrontation. Don't be the fence straddling fumbler saying, this isn't what you need, but here's an antibiotic just in case. So if this has ever happened to you before where you have had a confrontational encounter that has really pivoted your approach to this conversation, I'd love for you to share your experience. One of my upcoming videos, I'm going to be sharing my most traumatic encounter with a patient and her mother where I really struggled with this conversation that prompted me to figure this out. I wanted to know how to effectively have this conversation. Let me know in the comments, what's your most confrontational encounter you've had when it comes to saying no to an antibiotic? Another reason to avoid being the fence straddling fumbler. Say that 5 times fast. No thanks. All right, let's move on to prescriber type number 3, what I call the protocol purist. Now, these are your prescribers that live and die by the guidelines. They know what's right. They're going to do what's right. I can't say that I have fault finding there at all. The guidelines are important, but the delivery is what matters. So the protocol purist might be like, it's viral. I said what I said. Next. They're not interested in having a conversation explaining to you why they're holding your hand. I mean, hats off to them. They're not afraid to do what's right. They're not afraid of disappointment or confrontation. They're going to do what's right because it's what's right. The protocol purist is amazing for antibiotic stewardship. I appreciate them for that 110%. The backlash to this is they walk around with the impression that you don't know what you're talking about. They go somewhere else. Maybe they wind up on the side of the people pleaser. Then they're reinforced even further that they're right and you're wrong. They miss the opportunity for building patient relationship and educating for the long haul, which will impact future visits for the patient and for the provider. If we handle it right, when they come back in, those conversations get easier. So the protocol purists, amazing at antibiotic stewardship, amazing at doing what's right, but missing the opportunity to build trust and build relationship. Protocol purists, my challenge for you is to learn how to have these conversations. Although, secretly, every clinic wants a protocol purist, just for backup. Okay, moving on. Prescriber type number 4, the gut check gambler. This is the clinician that's like, well, the strep was negative, but my gut kind of says you need a Z-Pack. I mean, don't get me wrong. Nurse practitioners, we were nurses first. We know all about the gut check, and we were taught, listen to your gut. What I would challenge here is it the gut, or is it anxiousness about being wrong, missing something, or avoidance of not wanting to deal with confrontation, saying no to an antibiotic? I would say the anxiousness side that mimics a gut instinct is far more likely early in practice. We still have lots to experience and lots to learn, and we're just not sure, and we certainly don't want to miss anything. That prescriber is coming from a good intent, but still not doing the right thing. They're not exactly reckless, they're not evidence-based, and they think they're going with their gut. I mean, sometimes it works, for sure, but other times it's playing antibiotic roulette, basically. Have you ever been a gut check gambler before? If you have, drop it in the comments, but I want to know, was it truly a gut check, or do you think that there was anxiousness over missing something and being wrong, or avoidance that you blamed for a gut instinct? And listen, if that's been you, no judgment. It has been me before, and it definitely was early in practice many years ago. It happens to us all, I think. Most of us have been probably all three of these at some point in one day before in the middle of sick season. Where are my urgent care friends and my retail friends? You all deal with those URIs back to back to back in the middle of sick season. It's not quite the same in primary care. It takes longer to get in for an acute appointment these days with the shortages. God love you. Urgent care and retail health, you guys deal with this all the time. 17 URIs and it's not even lunchtime yet. Truly, you are the ones that absolutely need to craft this skill. We appreciate what you do on the front lines. All right, so far we've covered the first 4 of the 5 antibiotic prescriber types. I think you can recognize that we really don't want to be either of these. So you can thank the fact that I have 2 boys who both are into Star Wars for the naming of this 5th clinician type. That's what I call the Jedi Clinician. May the Force be with you. So the Jedi Clinician doesn't just say no to the antibiotic. They take the time to truly listen to the patient and then validate what's going on. That is what most patients are looking for. And that is an important aspect of having an effective clinical conversation with our patient. A lot of clinicians avoid this or rationalize skipping this. They say, I don't have the time. The more that you learn to craft having the conversation, the more you can do it in a time-efficient, effective manner. It does take some practice, and it does take grabbing some knowledge. If you've not grabbed that free guide yet, make sure that you do that, but it is a skill that you can build. Listen, validate, educated them on what would actually help, as well as educating them on why the antibiotic isn't needed in a way that builds trust and builds relationship with your patient. Again, most of us want to avoid this because we think we just don't have the time, but you can be the Jedi Clinician. If you've had that experience before where a patient has actually thanked you for not prescribing an antibiotic, even when they came in thinking that they needed one, and if you're looking at me like I have 3 heads right now, like I didn't even know that that was possible, I promise you that it is. Have you ever heard that before? Drop me a yes in the comments. Let me know what you feel like you said and what ways you connected and what was effective for you. Sharing that helps us all. It really just validates that you're building relationships with your patient, and that's one of the most gratifying experiences that you can have. Bottom line, the Jedi Clinician is combining education, empathy, and evidence while saying no to antibiotics. Okay, so let's recap the 5 prescriber types. Think about which one you are, at least most of the time. This will give you insight into what you need to focus on crafting the skill of saying no to unnecessary antibiotics. The first is the people pleaser who basically writes scripts just to avoid disappointing the patient. The second is the fence straddling fumbler. They will admit that an antibiotic isn't needed, but they'll prescribe it anyways because they want to avoid confrontation. The third is the protocol purist who sticks strictly to the guidelines. They don't really care how the patient feels about it. So I'm proud of them on the guidelines, but we have to really care about how the patient feels about it. All right, the fourth is the gut check gambler who just follows their instincts. I would challenge, is it gut instinct or is it ultimately anxiousness or avoidance? Anxiousness about how the patient's going to feel or avoidance wanting to avoid that confrontation. It's kind of a blend of prescriber number 1 and prescriber number 2, the people pleaser and the fence straddling fumbler. All right, and prescriber type number 5, the Jedi Clinician. That is the clinician that we all want to aim to be. And to become the Jedi Clinician, you have to hone the skill of having a clinically effective conversation with clarity and confidence, connecting with your patient, building trust and patient relationship. And it is absolutely possible. We were not taught how to have the conversations. We were taught the science and the protocols, but we weren't taught how to build relationship. Grab my free guide, the top 10 phrases. If you've got more questions, I'm here to help. I'm Mel, and I'll see you in the next one. And listen, if you think, yep, I've been on all 5 of these within the same season, that probably makes you totally normal. The one downside, and I'm rambling at this point, has anybody noticed this? I'll see you in the next one. but missing the opportunity to build trust and build relationship.